Good day. My name is Dr. Peter Koltai. I am Emeritus Professor of Otolaryngology and Pediatrics at Stanford University and one of the past presidents of the ABEA. In the next half hour or so, I will tell you about the early years in the career of Dr. Chevalier Jackson and how his journey relates to the story of the development of distal illumination for aerodigestive endoscopy. The desire to gaze into the deep recesses of the human body is an ancient quest. Realizing this goal into the practice of medicine in a safe, dependable manner did not happen till the beginning of the 20th century. At its core is a narrative about the technology of light, creating it, capturing it, directing it, and then understanding what it reveals. It is also a very human story of genius, creativity, compassion, and competition. It is the story of how Chevalier Jackson established the discipline of bronchoesophagology. I have no disclosures for this presentation. In an address to the nation in 1961, President Kennedy rephrased an ancient aphorism: failure is an orphan, but success has 1,000 fathers. Our story today is one of great success, and indeed, it is a story of many, many fathers. In 1854, Professor Samuel Gross, then at the University of Louisville, published a book entitled A Practical Treatise on Foreign Bodies in the Air Passages. Gross had trained at the University of Pennsylvania and was a direct heir to the legacy of Dr. Philip Singh Physick, considered by many the father of American surgery. In 1871, Dr. Gross commented on his book, quote, "It was the first attempt to systematize our knowledge on the subject, a pioneer work," unquote. Now, you may not recognize Dr. Gross from his picture in this slide. However, you may well be familiar with his famous portrait by the Philadelphia artist Thomas Eakins titled The Gross Clinic. Some critics with delicate sensibilities have commented that the title of the painting is most appropriate. Professor Gross was one of the eminent surgeons of his day, a cutting-edge practitioner. Interestingly, when you look inside his book, you find that his method of foreign body management depended upon a tracheotomy through which the offending object was retrieved with a variety of different, well-illustrated instruments. Professor Gross's technique was not very different from that of the 17th century military surgeon Nicholas Habicot, whose monograph, the first on the topic of tracheotomy, and with the first reported pediatric case of a boy who swallowed a bag of coins for fear of being robbed, which lodged in his esophagus and resulted in compressive airway obstruction. Through his surgical opening into the trachea, Dr. Habicot massaged the mass of coins down into the boy's stomach, saving his life. The coins were later retrieved by a more natural process. However, it is worth mentioning that for most victims in those days, foreign body aspiration was a fatal event. Before the 20th century, the rates of morbidity and mortality from aspiration exceeded 90%. In his book of 1880, Diseases of the Pharynx, Larynx, and Trachea, Mr. Morel Mackenzie, often referred to as the father of laryngology, writes, quote, "In this case, a boy aged 3 years received into his air passage a piece of bone, which was expelled 60 years later in a fit of coughing. The patient had suffered irregular intervals of hemoptysis, purulent expectoration, and for a long time from cough and dyspnea. but from the age of 28 and 48, he was well enough to do a little work. It is in this historical context that young Chevalier Jackson began his medical training at Jefferson Medical College in Philadelphia in 1883, where Dr. Samuel Gross was then professor of surgery. Also on the faculty of Jefferson was Dr. Jacob Solis Cohen, one of the original founders of the American Laryngologic Association. In his autobiography published in 1938, Jackson writes, quote, "The work of Drs. Gross and Solis Cohen had been interesting, and I had closely followed it at every opportunity during the college years." In his autobiography, Jackson writes, quote, "In my first year of practice, there was an event that called worldwide attention to the specialty of laryngology," unquote. This, of course, was the sad saga of Frederick the Noble. Crown Prince Frederick, heir to the throne of a newly united Germany, was a heavy smoker and in 1887 developed hoarseness. He was initially treated by Prussian physicians, but when he did not improve, Mr. Morrell Mackenzie was called upon from England for a consultation and performed several biopsies, which the eminent pathologist, Dr. Rudolf Virchow, declared to be benign. Just before Frederick's ascended to the throne in 1888, it became obvious that he had laryngeal cancer, and he died at the age of 56, 3 months after his coronation. Mackenzie, as well as all of England, became the scapegoats in the German press for the therapeutic failure. The historic importance of all of this was that Frederick was of a progressive and peaceful nature. His reactionary son and successor, Kaiser Wilhelm III, was under the influence of the militarists in the German army, which eventually led to the disaster of World War I. Following his graduation from Jefferson, and after a brief period of private practice, Jackson traveled to London for a fellowship with Morrell Mackenzie. In his biography, he writes, quote, "I made good use of my time in London. I saw an impractical device designed by Mackenzie to inspect the esophagus. By 1890, I had developed an esophagoscope worthy of the name." In his autobiography, Jackson writes, quote, "The development of the esophagoscope brought me a series of very sad cases. A girl, 7 years old, emaciated to a skeleton, had been found lying on the floor of a coal miner's shanty, her mother dying of pneumonia, her father on the floor in a drunken stupor. She had not taken a drop of water for a week. When she tried to swallow, she choked, and all the water came back through her nose and mouth. I put the esophagoscope between her parched lips and found a plug of grayish material, which I removed with delicate forceps. After removal of the instrument, she took a small sip of water. It went down slowly. She gently took hold of my hand and kissed it," unquote. This begs the question, how did the design of the new esophagoscope come to fruition and make foreign body extraction routine? The answer to this question is the story of modern endoscopy and the development of distal illumination. Endoscopy has many challenges, but the basic ones are, number one, utilizing openings into the body. Number two, delivering light into the viscera. Number three, transmitting an image back to the eye. Number four, expanding the field of vision. And number five, freedom from pain. Our focus for the remainder of this presentation will be the challenges of delivering light. In ancient times, getting sunlight into dark spaces was done by the Egyptians with multiple reflecting mirrors for the purpose of decorating the walls of their royal tombs. It was to be the basic source of lighting for attempts at endoscopy until the middle of the 19th century. For example, the 11th century Persian poet, mathematician, physicist, and physician known as Avicenna experimented with curved mirrors and lenses, and in the process discovered the law of refraction, today known as Snell's law. He used reflected sunlight from curved glass mirrors to examine the internal cavities of the body, such as the mouth, vagina, and anus. As we shall see later, sunlight was not totally abandoned. However, the early use of artificial light for looking into the body utilized candles reflected from curved mirrors, as illustrated in the published work of Mr. Archibald Clennon, a military surgeon from the 18th century who, quote, during his years with the regiment, developed several novel instruments which he demonstrated to the Royal Society, including a candle-powered illuminator for inspecting the eardrums, and was the first British practitioner to catheterize the eustachian tube. The first true endoscope was designed by Dr. Philipp Bozzini of Mainz, Germany, at the beginning of the 19th century. Quote, Bozzini called his device a Lichtleiter, or light conductor. It was constructed of a tube with various attachments to be inserted into a body cavity. A candle and angled mirrors inside the device enabled the physician to see inside the cavity. The Bozzini device was clearly of marginal utility. 30 years later, the French surgeon, Dr. Antonin Desormeaux, refined a Lichtleiter and utilized an alcohol and turpentine lamp for illumination. He coined the term endoscopy and published the first large series of surgical cases, including excision of papilloma, lysis of strictures, urethrotomies, and removal of bladder stones. Professor Adolf Kussmaul of Freiburg, Germany, was a leading clinician of his time, a prolific academic and practitioner in multiple disciplines in medicine and surgery. He adopted Desormeaux's endoscope and attempted the first gastroscopy, for which he hired a professional sword swallower. The experiment did not succeed as no view of the stomach was seen. However, he then adopted the technique for esophagoscopy with better visualization. But the weak proximal light source precluded any therapeutic utility. Clearly, a more intense and consistent light source was necessary. In this regard, experiments with the new science of electricity in the first half of the 19th century began to yield practical applications. Dr. Christopher Pfaff, a German physicist, chemist, and physician, a friend of Volta and Faraday, and an expert in electrical theory, discovered that a platinum wire coated with a thin layer of zinc glows with a bright, hot light when an electric current is applied to it. This innovation was fundamental for the early development of both endoscopy and electrosurgery. Recognizing the medical potential of Dr. Pfaff's discovery, in 1866, Julius Bruck from Breslau, Germany, a famous dentist and stomatologist of his era, designed the first endoscope with distal illumination for examination of the mouth and urethra. By inserting the hot platinum wire in a water-cooled glass jacket, he was able to prevent burn injury. He called it the galvanoscope. While there is little evidence for its utility for clinical use, it laid the groundwork for later refinement. In 1879, the Berlin surgeon, Professor Max Nitze, considered by many the father of urology, working with the brilliant Viennese engineer, Joseph Leiter, adapted and greatly improved Dr. Brooks' design into the first fully functional cystoscope with distal illumination, utilizing an enclosed water-cooled galvanized platinum wire. Leiter also designed the first telescope for distal magnified viewing of pathology. Sadly, a bitter fuse arose between the two men over the priority of the invention. Others quickly stepped into the breach and found novel uses for their device. In 1881, Professor Johannes Michelitz, a world-famous surgeon practicing in Vienna, worked with Joseph Leiter to adopt the distally illuminated cystoscope for both gastroscopy and esophagoscopy, primarily for diagnostic examination. However, due to the difficulty of working therapeutically with the endoscope channel occupied by the lighting and cooling apparatus, they took a step back from distal illumination and developed a proximal light source in the handle of the instrument, which projected light into the scope with a prism. Up until this time, endoscopy was used only for cystoscopy and esophagogastroscopy. The reason for this is that laryngoscopy and bronchoscopy had yet to be invented. The discipline of laryngology got a late start as a clinical specialty as a consequence of the false assumption that direct access to the voice box was not possible. Dr. Bozzini is credited with using the Lichtleiter as an early attempt at indirect laryngoscopy with one of his specula specifically designed for viewing the larynx. Little is documented of his observations. In his History of the Laryngoscope, Mr. Morel Mackenzie illustrates the laryngeal mirror of Dr. Benjamin Babington and writes, quote, "This instrument was exhibited by Dr. Babington at the Hunterian Society in 1829. In this country, where the sun very often does not shine brightly for weeks together, the art of laryngoscopy could never have flourished till artificial light had been substituted," unquote. After the work of Dr. Babington, there were several other physicians in the first half of the 19th century who reported viewing the larynx with a mirror. However, it was Manuel Garcia, a celebrity singing teacher of Spanish heritage, born in France and working in London, who conceived the idea of using a dental mirror for otoscopic viewing of his own larynx during singing. In 1855, he presented a paper to the Royal Society of London entitled Physiologic Observations of the Human Voice. He initially used sunlight as his source of illumination, but eventually adopted a head mirror and a kerosene lamp for his examinations of other people other than himself. A year later, in 1856, Ludwig Türk, an Austrian neurologist working in Vienna, unaware of the work of Manuel Garcia, built an apparatus for autoendoscopy and was making progress, but became frustrated by the lack of sufficient sunlight in winter and gave his instrument to a colleague, Dr. Johann Cermak of Budapest. Cermak, a physiologist and neurologist, was able to refine Türk's instrument and overcame the technical difficulties inherent to sunlit illumination for indirect laryngoscopy, primarily by the addition of an artificial light source, and published his observation before Turk was able to do so. The two became hostile enemies over the priority of the innovation known as the Turk Wars. The publicity of their rivalry in the international medical community had the beneficial effect of spreading the discovery of the new field of laryngology. And indeed, the Austro-Hungarian laryngoscopy controversy spread rapidly across Europe and to the United States. In America, Dr. Louis Ellsberg established a practice at New York University as the first professor of laryngology in the United States and became one of the original founders of the American Laryngological Association. In the United Kingdom, Mr. Morel Mackenzie developed an international clientele in the practice of laryngology and was the first professor of laryngology in Britain. Both Dr. Ellsberg and Mr. Mackenzie worked at improving the intensity of their indirect light sources. As I mentioned earlier, one of the key challenges to the success of endoscopy was freedom from pain. The development of anesthesia is a story all its own, but its early evolution coincided with the initial attempts at endoscopy and greatly facilitated its practice. Dr. William Morton at Harvard was the first to use ether as a surgical anesthetic, and Dr. Karl Kohler of Vienna is credited with recognizing the medicinal use of cocaine as a local anesthetic. Every book devoted to endoscopy from the late 19th century onward has chapters dedicated to anesthesia. As in medicine, technology was rapidly advancing in all fields of science, and this was especially true for electricity. Now, there is much controversy and scholarship about who really invented the light bulb. However, Thomas Edison's innovation and mass production of his electric light bulb beginning in 1880 was a historically unique event that was to change the world in uncountable ways. Its impact on medicine was enormous, particularly with the miniaturization of his invention. The first to apply a diminutive light bulb for endoscopy was Mr. David Newman in Glasgow, Scotland in 1883. A general surgeon who initially practiced urology, he designed a cystoscope for examining the bladder. He writes, quote, "The electric lamp is introduced through the urethra without being connected to the battery. It is important that the lamp should not be introduced before the circuit is complete, as if this precaution is not taken, the lamp is apt to become heated and may crack when it is passed into the fluid contents of the bladder," unquote. Interestingly, he eventually took up the practice of otolaryngology and wrote a respected book on the subject. By 1887, Dr. Nitze and Mr. Leiter, by now rivals and competitors, each produced nearly identical cystoscopes with distal illumination using small electric bulbs. Unfortunately, the heat from the bulbs and their short life remained obstacles and limited applicability to esophagoscopy and gastroscopy. The smaller light bulbs were now routinely manufactured, and in the United States, Dr. Horace Ivins, professor of laryngology at the Hahnemann Medical College in Philadelphia, adopted a dental mirror illuminated with an electric bulb for laryngoscopy. It is elegantly illustrated in his textbook of 1893. As I mentioned earlier, direct laryngoscopy was not thought to be possible due to the presumed inaccessibility of the larynx. However, a happy accident occurred in 1885 at one of Berlin University's clinics by a well-regarded endoscopist, Professor Theodor Rosenheim, who inadvertently passed an esophagoscope into the larynx and trachea. He found that he had a fine view of the trachea and bronchial bifurcation. Others in his department came quickly to take a look. One of those was Dr. Alfred Kirstein, a colleague of Rosenheim's working in the same Berlin clinic. He recognized the significance of Rosenheim's accident, and within weeks, Kirstein designed and fabricated the first direct laryngoscope. The light source remained proximal, built into the handle, and transmitted by a prism. In the same month, he presented his findings to the Berlin Medical Society. He established the principles of laryngoscopy, still used in practice today, and paved the way to bronchoscopy. He wrote, quote, "I convinced myself that one can pass the vocal cords intentionally with a middle-sized esophagoscope into the coconized trachea, right down to the bifurcation," unquote. With the prejudice against direct laryngoscopy abandoned, Dr. Gustav Kilian, a former student of Professor Adolf Kussmaul and a practicing laryngologist in Freiburg, Germany, recognized the importance of Alfred Kirstein's observations after attending Kirstein's lecture in Heidelberg at the Congress of German Laryngologists. He hired his clinic janitor to practice intubation of the trachea using cocaine anesthesia and a proximally lighted Michelitz esophagoscope. In his publication on the first bronchoscopy, Kilian writes, quote, "A farmer had ingested the piece of bone with his soup. Listening to his breathing, a wheezing noise could be heard in his right lung area. We used a Michelitz electric light esophagoscope and forceps to remove the bone splinter," unquote. Kilian became internationally famous for his development of the tools and techniques of bronchoscopy, including suspension. Interestingly, he continued to use proximal illumination, either with a reflective mirror or a headlight. In 1898, Charles Preston, an electrician and traveling salesman specializing in the medical application of early electric bulbs, visited Rochester, New York, and met urologist Henry Koch, and they formed a collaboration to develop a better light bulb for cystoscopy. Preston modified and miniaturized his larger bulbs down to 8 by 3 millimeters, reduced the amperage of the battery, and devised a carrier to place the bulb at the distal end of the scope. It came to be known as the Minion bulb. The reduced amperage provided a lower temperature, making it a cold bulb, safe for use adjacent to delicate tissues. In the new design, the bulb was easily replaceable and screwed into the endoscopic carrier. Dr. Koch designed his cystoscope with a side channel for the carrier and patented the new device in 1899. Other specialties quickly recognized the utility of the design, and Dr. Koch, recognizing a good business opportunity, established the Electrosurgical Company in 1901. The company is still in business today in Rochester, New York. In 1901, Dr. Max Einhorn, professor of medicine at the New York Medical School and one of the founders of the American Society of Gastroenterology, presented a report to the New York Medical Society entitled "A New Esophagoscope." He writes, quote, "More recently, the Electrosurgical Company of Rochester, New York, has succeeded in manufacturing so-called cold electric lamps. They generate very little heat without interruption of the current. These lamps have been used for urethrooscopy and proctoscopy. I have constructed a similar instrument for the esophagus. In 1904, Dr. Ephraim Ingalls, professor of laryngology at Rush Medical College in Chicago, published a report on his technique of bronchoscopy. He writes, quote, "I had the Kirstein lamp, indeed used it for a few minutes at the beginning of the operation, but in this particular case, I obtained better results with the small lamp introduced to near the distal end of the bronchoscope. One great advantage of this source of illumination is that the operation can be done in a lighted room, whereas with the Kirstein lamp, it must be in a darkened room." Our story now circles back to Chevalier Jackson, who, after returning from his Mackenzie Fellowship in 1889, established a practice in airway surgery in Pittsburgh, gaining experience, confidence, and recognition for the quality of his work and his regular publications in the journals of his day. In 1907, he publishes Tracheobronchoscopy, Esophagoscopy, and Gastroscopy, the first of his many books and the first book in English on the topic. It details his techniques of aerodigestive endoscopy, descriptions of his novel instruments, the importance of radiography, and provides self-drawn illustrations of pathology. From the start, he is using distal illumination with electric bulbs in his endoscopes, invents the famous slide laryngoscope with a removable bottom for bronchoscopy, and designs novel forceps for specific foreign bodies and surgical procedures in the aerodigestive tract. His innovations include biopsy forceps, a safety pin closure, suction aspirators, and many others, along with the battery packs for energizing his light bulbs. He demonstrates how to position the patient, the surgeon, and his assistants for each type of endoscopy, depending if he wants the patient to be sitting or recumbent. He provides the rationale for preoperative radiologic diagnosis with appropriate examples demonstrating the importance of having as much information ahead of surgery to reduce the time spent searching for the foreign bodies. This is the source of his famous aphorism, quote, 2-minute preparation, 2-hour surgery, 2-hour preparation, 2-minute surgery. He presents vivid drawings of his observations to facilitate flattening the learning curve for others in acquiring endoscopic skills. Dr. Jackson also begins what is to become the famous collection of several thousand foreign bodies, now on display at the Mutter Museum in Philadelphia. And perhaps most importantly, he establishes his lifelong commitment of teaching the next generation of endoscopists, using his ambidextrous artistic skills to demonstrate what he has observed in the operating room, organizing laboratory classes for practicing endoscopy on anesthetized animals, and begins a collaboration with the Pilling Company for manufacture of his many innovations, making them accessible for their widespread use. And in 1917, a decade after the publication of his first book, Dr. Jackson institutionalized the new specialty and founds the American Bronchoesophagologic Association. In 1977, 70 years after Chevalier Jackson published his first book, Tracheobronchoscopy, Esophagoscopy, and Gastroscopy, I began my residency in otolaryngology at the University of Texas, where I learned airway management using a Jackson endoscopy set made by Pilling. The longevity of his accomplishment is what impresses me the most. Behind the amazing accomplishments of Chevalier Jackson are many great men who devoted their creativity, ingenuity, their lives to see better in order to serve better. He was a giant among giants. Chevalier Jackson profoundly demonstrates the aphorism of Sir Isaac Newton: "If I have seen further than others, it is by standing on the shoulder of giants." Dr. Jackson used the novel technology of light bulbs to display his genius and saved thousands of lives in the process. He democratized the practice of endoscopy and taught several generations of young surgeons the skills necessary to carry on his legacy. He was a giant indeed. Thank you for this opportunity to tell you this wonderful story.